Welcome, everyone. We are so excited to have you here for the June Innovation Lounge, Where You Live, How Nurses Are Leading the Mobile Care Revolution. We're going to talk tonight about mobile care and how healthcare is coordinated, accessed, and delivered. And we are thrilled to have a panel of nursing experts who will discuss how mobile care strategies are improving health equity and providing long-term sustainable solutions to address the social determinants of health. At this time, I'd like to introduce our subject matter experts. Dr. Emily Bentley is the Director for Clinical Affairs and Assistant Professor at the University of South Alabama College of Nursing. Her nursing career focuses on working with medically underserved patients, leading interdisciplinary care teams, advancing nursing education, developing academic clinical partnerships, and advancing nursing leadership roles. Dr. Bentley is the project director for a HRSA-funded grant project titled Nursing Research and Education to Advance Culturally Aligned Healthcare. The project focuses on training nurses to become leaders in promoting health equity and addressing social determinants of health in the mobile care environment. Dr. Barbara Chapman is an assistant clinical professor and lead faculty in the family nurse practitioner and psychiatric mental health nurse practitioner programs at the University of Texas, Tyler. She has been a nurse for over 35 years and has practiced as a family nurse practitioner for over 9 years at the community healthcare clinic, focusing on providing care to the uninsured and medically underserved population at 200% or below the poverty level. She has also practiced as a family nurse practitioner on the Intune mobile unit and volunteered with the Health Wagon in West Virginia, providing mobile health care to rural and underserved populations throughout coal country. In 2022, she received the Texas Nurse Practitioners Presidential Award for her service and dedication to the profession. Dr. Kachita Jackson is a native of Greenville, North Carolina, and serves as the Vice President of Health Equity and Social Impact at ECU Health. In her role, Dr. Jackson uses data to drive change, quality improvement, community engagement, and equity. Her research interests include the nurse's role in health disparities, equity of care, nursing recruitment strategies, social drivers of health, and rural health care. She is the 2022 recipient of the ANA Innovation Individual Nurse Award, sponsored by Stryker, for her work on community pop-ups. And we are thrilled to have you all here this evening. At this time, I'd like to introduce Dr. Emily Bentley. Dr. Bentley, the floor is yours.
Thank you so much, and thank you for that kind introduction. Good evening to everyone. As Lois and Olivia stated, we are very excited about our presentation tonight and discussion, Care Where You Live, How Nurses Are Leading the Mobile Care Revolution. I'm here tonight to talk about the Nursing Reach Project. I am the Director for Clinical Affairs and Assistant Professor at the University of South Alabama and Project Director for the Nursing Reach Project. Therefore, I am early on in this project. I wanted to let everyone know kind of my role in this panel tonight is to talk about why we're doing the work we're doing and how to get started, how to get our feet off the ground. We started in October of 2022, and that's what I'll be focusing on throughout my presentation. Next slide. So as a grant awardee, I'm required to disclose that our program is funded by the Health Resources and Service Administration, and the contents of the presentation are those of the author, myself, and not necessarily represent the official view of HRSA, HSS, or the U.S. government. Next slide. So our project is the Nursing Reach Project. It's nursing recruitment and education to expand access to culturally aligned healthcare. We are offering recruitment and training opportunities to a diverse nursing workforce capable of providing culturally aligned healthcare in our rural and underserved communities of Alabama and Mississippi by expanding nurse-led interprofessional teams and specifically on mobile health units. Next slide. This project is a comprehensive or multifactorial project with 5 main objectives. First, to expand nurse-led mobile health units in our region. Second, to expand the nursing workforce that can lead these mobile health units, specifically on how to manage social determinants of health. Third, to enhance didactic curricula on social determinants of health, both with our students and faculty and some of our community partners. Fourth, to strengthen our community-based collaborations for evidence-based practice and quality improvement. And finally, to implement a system to recruit and support nursing students and faculty from diverse populations, including those from disadvantaged backgrounds and underrepresented racial and ethnic minorities. Next slide. So why nurses? Nurses are innovators. It's part of our history. You can't go to a nursing thing without hearing about Nightingale and her hand washing. I almost want to ring a bell every time I hear it, right? But there's a reason for that. It's part of our history, and it's part of our really our role identity. We have always been about holistic care, bedside care, and things that are patient-centered processes to improve the care of our patients. And really the natural next step in that, where we are technologically, is mobile health and telehealth. So why mobile health? Because of the healthcare disparities that exist. If things were working the way that they were working, we would just keep doing them the way that we were doing them. But locally in our 2021 needs assessment for our region, we identified that individuals that don't access care do it because of affordability, lack of insurance, lack of appointments, providers not accepting their insurance, the timing of those appointments, or lack of transportation or just availability. And I'm sure, even though this is a local needs assessment, I'm sure a lot of you can attest to these same things in your areas. Why nursing students? Because of community demographics. This particular project is, again, focused on Alabama and Mississippi. 35% of our population, but only 19% of our nursing workforce identifies as racially or ethnically diverse. So we have some room there. We have almost a 15% disparity there. In Mississippi, 41% of the population, but only 22% of nursing workforce identifies as racially or ethnically diverse. So again, almost 20% disparity there. We know that from research, when you have a nursing population that more closely mirrors your population, that healthcare outcomes are better. And why nursing students? The last thing is, if we are going to be leaders in the mobile care revolution, we have to train nursing students to do this, not just nurses in the community, but also our nursing students. Next slide. So we talked a little bit about why we're doing what we're doing. Now we're going to start talking about what we're doing. Some of my colleagues are going to go into these topics more in detail later. So I'm just going to stick with the fact that I really liked this infographic, that it really shows that 80% of healthcare is not really healthcare at all. It's not even access. It's all of the other things that go into making a person what they are and making their living situation or just their day-to-day life what it is. Socioeconomic factors, the physical environment, health behaviors, all of those things. What we've been talking about with our students and faculty since this whole project started is it's difficult for us to talk about hypertension with clients and patients when they don't know when their next meal is coming from. It's difficult to talk to patients about how things are going to affect their healthcare months or even years down the road when they don't feel safe in their environment today. So we have to meet these patients where they're at today, plan and help them plan for the next step, and then advocate for health policy that focuses on these other areas. Next slide. So what can nurses do? We can lead education and awareness in your workplace. All of you come from different backgrounds. Some of you are clinicians, some of you are educators, some of you are administrators and may work in boards of nursing, et cetera. And a lot of us do multiple of those things, right? Because we're nurses. But we can all lead education and awareness in this area. We can implement new care models. We're going to talk about 3 of them tonight: mobile health units, some telehealth and telementoring. We can research and develop partnerships related to social determinants of health. Any nurse can do a little research or network to find a best practice to address a problem. It may not be the best fix today, but it may be a step towards that best fix. So I want to talk about that a little bit later as well. And then finally, advanced social determinants of health data. So if a survey comes across your desk, answer it. If you are involved in any kind of QI, either in your place of work or in your community, how can you incorporate social determinants of health into that QI, into that data gathering, and just into the policies and the procedures that you're creating for your work environments? Next slide. So mobile health units, where you get to talk about mobile health units. This is such a fun thing to do, to get out into the communities and to do this work. So these mobile health units now are amazing. You can see some of the pictures on these slides. This is one of the units that we do work in. All of our units look very similar. We have some of these units have 1 to 4 exam rooms. They have bathrooms for UAs and STI testing, serum lab equipment, triage areas, supply closets, even pharmacy and immunizations, computer stations. And then some of these units, not the ones we're working in per se, but some of these units are very complex. They have radiology and mammogram equipment. They have dialysis equipment, endoscopy equipment, dentistry, biocontainment. Really, the implications for this modality of care are very far-reaching. And then the last thing I wanted to say is it doesn't take, $50,000 or $500,000 to get this process started. A lot of us will start with a pop-up tent, a table, and some basic screening equipment, just to get out in the community, start that networking, start that process of engagement, and then growing from there as you're looking for resources to do more and more and more in the community. Next slide. So a few more pictures from our mobile health units. We have the privilege to work with 3 units in our community. We have 3 organizations that have these large RV units. And we, in our project, are funding additional deployments for these units. So these units became underutilized during COVID for obvious reasons, but also just for good reasons. They were doing screenings and immunizations for COVID, but now we're trying to transition all of our units back into the community into doing as much as they can do. So that's part of what we're funding. We do all kinds of things, mostly health screenings and immunizations. We do them at community centers. We've done them in city spaces and at churches in the parking lot. We've done them at homeless shelters, women's shelters, daycare, and preschool. We've done Head Start physicals, all of those types of things. Sometimes, if the place allows for it, we can even do complete histories and physicals, urgent care, initiating primary care, again, drawing labs and doing all the things. And then finally, we've done a number of targeted health fairs and health education events where, again, sometimes we have a unit, but we don't use the unit that day because it's more appropriate to go inside and be part of their event. Or sometimes we park in the parking lot and be there during the event. It's all kind of dependent on what the needs are of those organizations in those areas at that time. Next slide. Next, develop some partnerships. One of the partnerships that we've developed is with Feeding the Gulf Coast. Part of the issue with mobile health units, at least in our region, is fostering participation and trust with the communities that we are serving and partnering with either individuals, again, churches or organizations that already have that trust, and engaging with those gatekeepers is really key to doing that work in a lot of regions, but definitely in our region. Feeding the Gulf Coast already has some of that trust established. So what we've done is fund some of the collaborative events where they'll do these food distributions. And then we know that 100 to 300 families will be there on that day that need services that could potentially need other services like healthcare services. So those are some of the partnerships that we're developing. Next slide. And lastly, I just wanted to briefly talk about Project ECHO. This is a telementoring program to extend community healthcare outcomes, extension for community healthcare outcomes, rather. And it is a project that was developed by Dr. Rohr at the University of New Mexico Health Sciences to push university and specialty expertise out in the community. What he recognized as a specialist is that patients were dying waiting on treatment that he could provide. And if he could teach people in the community how to do this type of work, then the right knowledge, the right place could save millions of lives. So we are engaging in this process. Next slide. At South Alabama, our goal is to create centers of excellence dedicated to increasing knowledge and awareness of healthcare treatment and primary care. We're already doing some things in mental health and integrated healthcare with Project ECHO at our college. But this summer, with the Nursing Reach project, we're going to start enhancing some of the didactic curriculum out to our community and community partners. on social determinants of health and health equity concepts for our students, our community, and our healthcare workers to try to increase education on these topics in our community. And also just an invitation. This is our link here on this website. All of these things are free. There are no cost to participate, free continuing education credits available and for eligible participants, which essentially are nurses. So if you're interested in any of those topics, feel free to join us. Next slide. So finally, what can you do? First of all, look at what your community needs and look at ways to prove what you need. When you start looking for funding, when you start looking to network, you're going to need to not only know what your community needs, but you're going to need to be able to prove it. Anytime that you have that data, going back to social determinants of health, going back to data, anytime you have resources to prove it really helps towards this whole process. So there's some resources on this page. We'll talk about it in a minute. And then look for funding that's the right fit for your goal. If you're part of a university or a federally qualified healthcare center or another larger type of organization, then it could be federal or industry type of funding. But it's not limited to that kind of funding. Local churches and local charities and foundations often fund this work initially to start with, especially in our region. Again, we have other mobile health units in our region that we're not partnering with that were 100% funded by a local church, those types of activities. So again, network, find like-minded individuals in your community that have passion for the same thing you do, and you can start doing this work. And then finally, don't get discouraged and overwhelmed. I can tell you I've been dabbling in some of this for about 10 years and was mostly unsuccessful. I've written grants, I've done different things, but I was always able to at least network and get something accomplished, but maybe not what I wanted to. And it really took the right team at the right time to get this larger project off the ground. But kind of the take-home message is don't get discouraged, don't get overwhelmed. Everybody can do a little bit of something in here. And some of my colleagues will talk to you about other things tonight. Next slide. These are just a few resources that will be in the slide deck for, again, that data, mobile health map for mobile health units. Now, this was only updated through about 2020, and then Project Echo. Next slide. References and any quick questions.
Dr. Bentley, I have just a follow-up question for you. One of your slides indicated that 50% of the socioeconomic factors, including education, job status, and community safety, can be linked back to someone's zip code. Can you share how Nursing Reach Project has been able to impact some of those socioeconomic factors of healthcare?
Well, I have some great community partners in this, Feeding the Gulf Coast and some of our other federally qualified healthcare centers. They have a lot of these resources available, and we have other resources in our community. The big take-home message with this is knowing what resources are available in community and to start networking and building from there. So that's really what we've tried to do over the first year of this project. Again, we're new, is figuring out what's out there and then making sure that our community knows about it.
Wonderful. Thank you so much for such an insightful presentation. If anyone has any questions for Dr. Bentley, if you can please put them in the chat. We will be circling back to all of the questions at the very end of the three presentations and look forward to a very robust discussion at that time. Now I'd like to share the floor with Dr. Barbara Chapman. Barbara, if you are on mute.
I'm on mute, sorry. I apologize. Thank you for the introduction. And thank you, Dr. Bentley, for actually some of the information that you said, meeting patients where they are. That is so important. That is such a critical component of mobile health care. And I really appreciate that. So I am Dr. Barbara Chapman. I am a clinical assistant professor at the University of Texas at Tyler, where I teach in both the family nurse practitioner program and the psychiatric practitioner program. So I was fortunate to be able to, I wanted to put this first slide up, and I appreciate that. This was part of our Intune mobile unit, and this was funded by a HRSA grant as well. And it was written by Dr. Carol Reiser and others from the University of Texas at Tyler. And the Intune mobile unit, this is a picture of the ceremony when we unveiled this in July of 2019. So Mobile Healthcare Clinic was created in part with a collaboration with from the university and a federally federally qualified healthcare center, Special Health Resources, with Dr. Carol Reiser as our fearless leader. I wish she was here this evening, as our primary investigator. So this particular primary clinic had 2 exam rooms, lab capabilities where patients can have point of care services. And we, while making healthcare mobile and accessible to those who live in these areas where we are, because we have such a shortage of providers here in Texas. We even had some of the state representatives attend. As a matter of fact, House Representative Stephanie Click came via Zoom at that time, which was not done, and really endorsed this product because she said, quote unquote, Texas has lost more rural hospitals than any other state, who also, and she said, I hope that this will become a model for the rest of the state. So next slide, please. So here is a picture of what our original Intune mobile unit looked like. This was the very first one that we started. We actually got this from it was partnered with Special Health. They had the little mobile unit. It was in a field full of grass up to your knees. And I was fortunate to be able to go out and look at it and see it. And it had been just so neglected and left just out in this field by itself. And I looked at the gentleman and I said, it's perfect. We'll take it. And so we were able to then get this unit and revamp the whole thing. We went all the way on the inside, completely renovating it, recovered it, put 2 exam rooms in it. I stocked it with every imaginable type of medical device you could think of. We were able to do testing on this, see patients on this. And so on this particular unit, we had a very small team. You can see some of us. Oh, I got some of us cut off over here on the side. But it was myself, Ms. Carrie Kennel, a licensed social worker, and then various clinical staff. And we were able to go to multiple locations. We were pulled in this unit to areas in East Texas, and we provided both primary care services as well as behavioral health care services to our rural and underserved areas. And some of the places where we have visited were little towns like New Summerfield, Dangerfield, Ore City, Kilgore, and as well as Longview in the Tyler area. We had the opportunity to see hundreds of patients who didn't have access to primary care or mental health care. And I tell you, partnering with that FQHC really allowed us the capability to have the EHR system in place, the computers in place. We connected to Wi-Fi, and then they were connected to that FQHC, where they then had access to referrals to the specialty. And because it's an FQHC designation, it allowed patients who had no insurance all the way up to those who were fully insured, because it was on a sliding scale process. So next slide, please. So I wanted to talk a little bit about the provider shortage. We have a tremendous provider shortage. This was back in 2020. It's worse now. 20,000 primary care physicians in the United States were predicted, and it's worse than that now. And obviously, the shortage primarily affects rural and underserved communities. Next slide. So this is another thing I wanted to speak to. By 2023, there's going to be a shortfall. The demographics specifically talk about population and aging, and the the primary care driver of increasing demand from 2018 to 2033. So during this period right now, the United States population is projecting a growth of 10.4%. From where we are right now is about 327 million to 361 million. So the United States population under 18 years of age is projected to grow 3.9%, while the population over 65 is projected to grow 45.1% by 2033. So the demand for providers in specialty areas, predominantly care of older patients, is going to do nothing but continue to increase. Thank you. Next slide. So talk, and I think we need to click this again, possibly. There you go. I'm sorry, it does that. So right now, there are over 2,000 mobile clinics located across the United States, and that includes Washington, D.C. Now, 44% of these mobile clinics provide primary care, pediatric care, and disease management. And 42% of them also include preventative and behavioral health care services, because we've got to start looking at how do we combine our care. That is primary care is where people go to for their first touch point. And so we've got to look at how do we incorporate primary and behavioral health care. Next slide. So I wanted to include this because this was a slide that I've had, and I've worked with this one. So mobile healthcare increases access to mobile clinics, and increases actually to 6.5 million visits annually. And this includes not just rural or underserved, but also urban communities. 39% of these serve in cities, 14% will serve in rural, and 47% actually serve in both. And per year, it's estimated that by having these in place, we can get approximately 600 fewer emergency visits. Go ahead, next slide. Oh, so why East Texas, where we started this? Well, in East Texas right now, we've got improved patient outcomes. This you can see at this. We pulled out this little quadrant here. Improved patient care outcomes when preventative and primary care services are provided. This is what we're seeing. Mobile clinics were successful in reaching 43% of men and 57% of women. And this is the demographic where we are. In these 35 counties in Northeast Texas are ranked in the worst healthcare outcome score for all of the counties in Texas. You can see the dark blue ranks 192nd to worst healthcare outcomes. Next slide. So I wanted to talk a little bit about this little device here. So point of care services, which is another thing Dr. Bentley discussed. This machine was transformational in us providing care to the community. It is having a point of care diagnostic service is just really incredible. This is the Piccolo Plus. We were able to purchase this as part of the grant. This is an Abbott Laboratories device. I have no tie to Abbott Laboratories, but I was able to purchase this device, and this allows us to do comprehensive comprehensive metabolic panels, lipid panels. You can choose your panel that you would like to run, and you can see on this slide there's a circle. That's the panel that will be run. You only need 0.1 cc of blood. Therefore, it's CLIA waived, so you don't even need a CLIA certificate to get that done. I can get these results back to the patients in 12 minutes. So having these machines, or more than one of these machines running simultaneously, that eliminates waiting time and allows for immediate treatment. And that way we can have target that need-based community and, increase patient outcomes. And then early treatment for the chronic diseases such as diabetes, hypertension, overall health and quality of life, reduces the burden of the medical costs, and again, reduces the hospital emergency room department visits. Next slide. Okay, so this is a slide that talks about, I liked this one because access to treatment is very severely limited, and it speaks to that. So rural Americans really have to travel twice as far as others to reach a hospital, and they're 2 times as likely to lack broadband internet, and that limits their access to telehealth. I see this all the time in Texas, where we have such a large state, where we have deserts where there is no internet. Even in East Texas, you can go from one street to another and it limits your internet service. So right now, 25 plus million rural Americans live in a mental health care provider shortage area. You can go to the next slide. I brought this slide on too, because this is a map that I just got for 2022, and it is an access to care ranking map. The darker the actual color of the state indicates what that access to healthcare is, what that access to this is particularly mental health care. As you can see in Texas, we are ranked 51. So there are 50 states in the United States. We are below Guam. So we must do something to increase our access to mental health care in the state of Texas. Next slide. Okay, so I wanted to just put some statistics up, and this is even about a year old, so I think it's higher. Depression costs over the United States over $50 billion a year. More than 9.5 million Americans suffer, 19 million Americans, 9.5% suffer with depression. And then it's easy to do screenings. The USPSTF recommends screenings now to be a standard component. I think we've all seen that, but tools even such as the PQH2 or 9, the Columbia Suicide Rating Scale, and the GAD-7 are very, very helpful in measuring the severity of depression when you come across that in primary care. Next slide. So some quick facts, because I'm going to switch a little bit to what's happening in the mental health care world. 1 in 5 adults experiences mental health illness each year. 1 in 20 experiences serious mental health. 1 in 6 youth 16 to 17 experience a mental health care issue annually, and 50% of mental health care issues start by age 14, and 75% by 24. Suicide is the second leading cause of death among people aged 10 to 14. That's third grade. All right, next slide. Okay, so another slide that I came across and something that I've spoken to is a study that I found from Blue Cross Blue Shield that also speaks to millennials and how they're struggling. Blue Cross Blue Shield did a study where they found that workers under 30 were more likely to consider suicide. 150,000 patients records indicated the millennials were 5 times more likely to consider suicide than baby boomers. So 80% of those with symptoms right now of clinical depression are not receiving help. Slide. I wanted to bring up this one because it's so important, especially in our state, as it is most states. But we have an organization here called CPAN, the Child Psychiatric Access Network. And on another day, I will speak to you all about that. But this slide was provided to me by them. And this shows the mental health care. 70% of youth 16 to 17 have mental health disorders. 75% of mental health care needs are met in primary care. That's why we have to do these collaborative care models. It's going to be critical moving forward, especially with the new CMS rules that are coming out. And again, as I spoke to, suicide is the second cause of death, age 10 to 24. That was in 2017, and it's worse now. So 51% of these are adolescent girls and 4% are adolescent boys. So next slide. Oh, and trauma. Trauma is another one. And I also wanted to put this up there because this speaks specifically, and it's worse now, this is 2017, speaks to the state of Texas. When you look at, this is a map per 100,000 children, ages 0 to 17. Now, these are counties in the state of Texas with at least one child and adolescent psychiatry person. Now, these counties are over here in East Texas, you can see, are the least served in the bright red. And if you think about 100,000 children, I don't know where y'all are tonight, but 100,000 people is about the seating capacity of the Los Angeles Memorial Coliseum. It's a big space. So right now in Bowie County, which is over here in East Texas, with a population of 22,000, we have 2. In Gregg County, which is a little bit bigger, 31,000, we have none. We have none. Moving down through the list, Nacogdoches down here in Nac, there's 15,000 people and there's none. There are none. In Smith County, which is where the university is, we have a medical school there, and there are, as a CPAN hub, Child Psychiatric Access Network hub on campus. Right now they have 10. The rest of the state has 0. The rest of the state has 0. So you can see why this is so important for us to increase access to our children across the state of Texas. And I was told by CPAN that these numbers have even gone down. I don't know where they could have gone down for, but they have. So next slide. Okay, so then we had to pivot. So in COVID, and Emily mentioned that they did not use their mobiles they weren't as usable as ours was. We used our mobile in COVID. We pivoted, we changed the way we did almost everything. We had our small staff went to tenfold, and we provided COVID tests and mental health care outreach to multiple communities, to the point where we were at almost 200 tests a day. Next slide. So doing this. Now, what happened in COVID happened in universities. It happened all across the country. And what we saw specifically with our community partners, was the tremendous nature that the pandemic took on the mental health care toll. And all of the things that we've talked about: fearful, anxious, stressed, exhausted. Many people were suffering burnout, skills to be effective in their lives. They couldn't do this. Nobody was practicing active self-care. Or developing boundaries. And this was difficult, especially for those in rural healthcare situations. So you can do the next slide. So these are just some of the things we spoke to. We all saw this. PTSD prevalent in 60% of physicians, nurses, and medical residents during COVID-19. And we have found studies that it's going to continue for the next several years. But there was another group that we felt were left out of this pandemic. Next slide, please. And this was because we saw this, we realized that we had trouble with our students in the psychiatric nurse practitioner program. And because we knew we had integral based student care with our educators, our community partners from UT Tyler, especially Ms. Brittany Childs, brought to our attention a special need that existed between the educators in the community and who were struggling with some of the same issues that the healthcare workers were. And so at the university, we collaborated with the UT school-based research and instruction and the Office of Community Engagement, and we decided to come up with a solution. And partnering with those teams of faculty, administrators, and students, we decided that we needed to help address this critical mental health care across the state of Texas. I showed you a few of those slides. And also during that time, it helped our PMHNP students receive the clinical hours that they needed because they were not able to get into those clinics to get those hours that were required. Next slide. Well, there it is. So what is the solution? So Dr. Sandra Peterson, who's the director of the PMHNP program, and I looked at how are we going to provide a solution to this? And one of the things we talked about was offering a free telemedicine and mental health care services to educators and healthcare workers in the area, assisted by our PMHNP students. So what we did was we partnered with these folks. We started our own outreach line. We put our students in for clinical hours. As the clinical instructor for that program, I teach the students what they're looking for. I train them. There's a training program. I then mentor them. When they go into the outreach line, I know they're in. When somebody books an appointment, I know they're there. It's a free service that provides online venue for essential workers so that they can receive this mental health care that they need. When a person makes an appointment, and you can make your appointment on certain hours, and if the student's available, that's who you partner with. I get an email, the student gets an email, the patient gets an email, and Dr. Peterson gets an email. Everybody knows who's on that line at any time. So, and that's our link to the mental health care resources for educators and healthcare workers. Next slide. Okay, so this really provided cutting edge technology that served as a basis for future collaborations. I just had a meeting last week with the dean of our new medical school. We're trying to decide, can we partner with our medical cohorts? How do I get the medical students in on this line? They need to be there because they also need to see what's happening in the community. We were the first to do it in Texas. I believe we're the only ones still doing it. We want to incorporate other teams, interprofessional teams, pharmacy, behavioral health. I want to put as many folks on this free outreach line as we can, and psychology and the telehealth teams. Okay, next slide. And I think we're about done. It's going well. We have seen way more than 500 clinical hours to date. We're probably at double or triple that. So it's going very well right now. Next slide. And so the benefits of this, the benefits of technology on this improves access to mental health care, brings patients to health care by reducing transportation barriers. When you integrate behavioral care and primary care, that leads to better patient outcomes. Again, we're going to reduce emergency visits. It's going to reduce their delay in care, and it's going to reduce their need for time off to get to these, to do the distance. And it improves community and follow-up care. I think there's one more. Yep. And so the students are doing great. The students, what this helps in our program is that they hone their skills in mental health care services. They learn to assist the clients in identifying their mental health care needs. It helps connect our students with the people in the community, and it serves them well throughout their careers. We're working on a telehealth certificate, and we can graduate practice ready immediately students so they can join the healthcare workforce as competent, well-prepared providers. Next slide. Yes. So here's the providing hope through mobile care and telepsychiatry services. And the outcomes are improved patient, family, and community health. Thank you so much.
Thank you so much, Dr. Chapman. Just an enlightening presentation. We're excited to get to the questions, but
Yes.
Before the Q&A, I'd like to hand the floor over to Dr. Kashida Jackson.
Okay.
Good afternoon, everyone. Again, it is a pleasure to be able to be here with you tonight. Following Dr. Bentley and Dr. Chapman, I was listening to their presentation and I kept thinking, everyone's going to think that we planned this together, but it's truly just our innovation and our work of what we're trying to do just in different parts of the country. I bring you greetings from Eastern North Carolina. I like to think that we have the most beautiful beaches, the largest mosquitoes, first in flight, and also hospitality. I'm the Vice President of Health Equity, Social Impact. I've worked here at our health system for a little over 25 years. Please go to the next slide. So everything that we do, we try really hard to align it back to our mission, our values, and our vision. When we look at our work, the first thing we ask, is it directional? Is it tied to our mission? We use the values of ICEs, where it goes to integrity, education, safety, compassion, accountability, and teamwork. And if something is off, we may have to put that to the side for a while because we always want to make sure that we are true to what our values are. Next slide, please. I mentioned that we have beautiful beaches, and I put this slide here because I liken back to when I take my children to the beach. And when we go to the beach, we all build these sand castles. I build one, my boys build one, they end up breaking them. No one has a good time. But when we work together, we create something amazing sometimes. So it's not realistic that every time we're going to make a beautiful sandcastle, but a lot of times we will do something amazing when we work side by side, when we have a focused goal, when we're listening to each other, when everyone has a purpose of what we're trying to do for the community. When we do it alone, we get this one little sad bucket of sand, has no direction. It doesn't look like it serves a purpose. And more than likely, a dog or a person will just stomp on it. So when we created our statement, we wanted our statement to truly look at who we were trying to serve. We played around with our statement for a long time, and we came to this statement. And I'll read it to you. I know it's on the board, but it really means a lot to me, so I definitely want to read it out loud. At ECU Health, every human, not person, every human will have a just opportunity to be as healthy as possible with intentional care to achieve it. Next slide, please. So I spoke about, I'm from Eastern North Carolina. We have 100 counties in our state. Out of those 100 counties, 78 of those are in rural North Carolina. Of those 78, 33 of those, we have the privilege of taking care of 1.4 million individuals or patrons or customers or patients or family members or vendors who come to our organization. We have 9 hospitals all throughout the state, Eastern North Carolina. But when you look at us, we are red. We use the social vulnerability to look at our state, to look at our state of affairs. The higher you are in social factors, risk for other risk factors, not having transportation, not having access to grocery stores, living in crowded homes, education factors, the redder your location will be. There's a score of 0 to 100. The closer you are to 100, the redder your location will be. If you look at this line here, and I'm drawing a line like you can see me drawing it. I don't control this line. But if you look at this line, everything to the right is where we're located, and we're extremely red. Couple of pockets of green, but everything is extremely red. Next slide, please. So that tells you that we have a lot of ground to cover and a lot of opportunities to throw a lot of noodles at the wall. That's what I call our innovation, is throwing noodles at the wall. Not just throwing things and going out and figuring out how to do things, but we throw something. If it sticks, we go with it. Meaning, do we get buy-in? Is it something that we can show data to support it? Does it make sense for us to focus on it? When you look at this data, you see the largest area is socioeconomic factors. So when we started this project, we recognized that we were the largest employer in our community. So we're an anchor for our community. Vendors use us, families are employed by us. We provide not only healthcare, but we provide we provide life to people in our communities, those 33 counties that we support. So when we looked at that, we can't just take care of health care without taking care of human care. Hence the reason we said human. So we started looking at education, employment, income, family support, safety. When we looked at that, we recognized we could put those into other buckets. Who are we hiring? Why are we not hiring those individuals? Who are we purchasing from? Why are we not purchasing from them? And who should we invest in? In a disclaimer, we're a part of an organization called Healthcare Anchor Network, which has 70 other organizations who are helping us think this way and push resources into our community. We should buy local. Our farmers who are here, our hospitals sit in the middle of cornfields, tobacco fields, bean fields. That's who we should be purchasing from to put that money back into our community. So we started with the social factors first, backing our way into healthcare. Next slide, please. Using our CHNA, it showed us where we should spend a lot of our focus areas. So we took the wheel from Healthy People 2030, and we started breaking it up into buckets, looking at awareness. When Olivia read my introduction, she mentioned the word of data. I love looking at numbers, not balancing things, not spending money. I just love looking at numbers because numbers tell your story. So we needed to start with our data. We needed to know who our patients were, where our patients were, who are our patients, why are our patients dying, why are they not choosing us? So we started with reals, race, ethnicity, language, and sex, knowing where our patients were so we can put them in buckets so that we can make sure that we were focused on the right area so we could reduce our recidivism rates. When we went into the communities, we knew which communities to go into. We knew the churches that were there. We knew who were the formal, informal leaders. We knew who to talk to and who could get the message out to the community. The mayor in certain communities was not the leader. They were just there in offices. It was Miss Rhymes, who everybody knew in Bethel. That's who we talked to, and that is who got people to our community events, and that's who started trusting us. That is how we were able to get into certain communities because someone would give us, for lack of better words, street cred. They said, trust them. They're here. They're going to show up. Watch, let me call her. She's going to answer the phone. And they called all times of the day. So I had to get a company phone because they were calling me all different times of the night. But they needed to see if they called, would someone answer? I told them, if you know someone that wants a job, we're giving away jobs. So they started sending family friends who couldn't get a job because they've always said that you have to know someone to get into the hospital. So they knew someone. They had a whole department that they could contact. So that was that acceptability and accommodation. We listened to what they were saying. We had to take a seat a lot of times because we recognized we had a lot of things that we had to make up for. Years ago, our hospital was set in a location that was not welcoming to some people. But we had to sit and listen and try to rectify those issues, those concerns, that pain that individuals had. So then accessibility. We took our healthcare to the people. We learned in nursing school, and many on this call, we learned that we should not have the patient come to us. We should go to the people. We should go to the patients. So we started doing that. We started popping up tents because I didn't have a budget for a van, which I have tried. I put it in my budget. But I was not going to allow not having something mobile because I drive a big truck. So my truck became the mobile unit, and we started going out into the community and popping up tents. And we would go to non-traditional locations such as ball fields, farms, baseball fields, where people were. And when we showed up, they saw our purple tents. At the time it was blue. And they would come and ask, what are you all doing here? We're giving away jobs. We're taking blood pressures. We're listening. We're signing people up for healthcare. We're doing all the things that you are asking us to do, but we're coming to you. Next slide, please. But we had to have a focus. We couldn't just say we're going here. We had to have a focus. So in 2020, March 13, everyone probably remembered where they were that day when they found out that our world forever was going to change. I was at the local food line, in line, buying toilet paper, like everyone else probably at that time. And we were trying to understand what this thing was, this COVID, this flu, this cold. What is this? Well, finally, we got on the other side of that 2020. We started to understand that in order to get people to get the vaccine, we had to understand that they were not going to get certain populations, were not going to get the vaccine because of, you can fill in the blank there. Certain people weren't going to come to our locations if we had flashing lights there. We thought it was really nice, but certain populations wouldn't come because the flashing lights were the police. So we had to listen to our population and make things acceptable and accessible for them. So we created a health equity department. And luckily, it's almost 2 years that we've had that department. And in that work, we started inviting people from the community for us to listen to them, not them listening to us, but us listening to them. And we started saying words like, we care. We're going to show up. I understand. You're right. That always wins when you say you're right. And we started putting our dollars, our people in locations where people really wanted us to be. So this is just a model. You see, our plan is to go out to 2025, but our goal is to continue to improve what healthcare will look like. We don't have a lot of dollars in North Carolina. Thankfully, Medicaid expansion is coming, but it has not come yet. The paper, they're still waving the paper, but I heard someone has a pen in their hand that we're going to sign very soon. Next slide, please. So data. Remember I mentioned social vulnerability, reels. We needed to know who our patients were, what population was spending or absorbing the most of our healthcare and not paying that dollar back, because we do run a healthcare organization. So we have to have funding so I can get my bus. That is what the goal is. They focus on what your goal. So we took this data and we laid it there and we did it by race. So we knew which population, which race, which insured was or was not getting healthcare. If people were using our ED for primary care, and they were uninsured, that's a location that we need to go and do a pop-up. We need to go to where that location is. If they're using our ED for primary care for things like blood pressure management, we need to go there. If they're using things for stomach pain or a rash, we need to give them ECU Now. It's our telemedicine program, so they can use that for free and they can use it everywhere. So we needed to know where our patients were so we could be directional in our care. Next slide, please. So these are our pop-ups. Literally, we were popping up tents. And we would go, the first picture you see with the blue tent, we're at a gym. It was opening day. No, it wasn't. It was opening day at Jackie Robinson baseball field. So we knew that we could expect 200 to 300 people there that day. So we went there. The coaches are primarily older Black males who don't typically go to the doctor. But we knew if I went there as a Black female, I would be seen as someone that was nagging. My husband said I have a tendency to do that at times, but I just like for him to do what needs to be done. So I was not the person to talk to those males. So we created a male health group where they went to our pop-ups and they talked to the males, which was surprising because they said the same thing I said, but they said it in a different tone. What's going on, man? I see your blood pressure is high. You good? What do you need to talk about? And they had a conversation, and it was more of, this is where you need to go. Oh, this is what's occurring. This is what you need to do. Then if the person said something like, I don't have insurance, they would wave. Someone would come over and talk, or they could just walk, because we had strategically placed our screenings by insurance. We had our jobs located in the building, so no one would see you. But they could go from one point to the next. It was a one-stop shop. Mental health was there, employment was there. We tried to do hiring on site. That doesn't work all the time, but you would have someone to vouch for you when you apply for a position. So that individual would send that to the recruiter, to the hiring manager, to say, I spoke with Olivia. She came there. She was a little nervous, but I think if you talk to her and you give her a chance, she would be a great candidate, a great team member for your team. Then we had an open grocery store. Everything was free. What we did not want to do is give people bags of food. We did that. People took it. They were very appreciative. But this way, it goes back to integrity. We wanted people to grocery shop and get what they like. Surprisingly, no one likes beets except for me. So I got all the beets. But they were getting the beets in the bag, and they were like, oh, this is great. I got the beets in the bag. I'm like, this is wonderful. We're all different. But they go to the cart. They weren't taking all of the food. They were getting enough because they cared about their community. Next slide, please. That's another example of us showing up and improving our trust. So in the middle slide, we're at a farm. That's the School of Nursing Instructors for Community Health, because our goal there is to take students to go into the community and start teaching our lay workers blood pressures. They learned that in the first semester of nursing, the best way to get really good at hearing the thump is that you go out and teach someone what the thump is. So they're going out. The first slide, the first picture, that young lady, that's our insurance. That's Access East. So she's there talking about insurance. It was during open enrollment. And then the last picture with the young lady with the red jacket on, that is our sheriff. So when we have these events, she shows up. Another way to build trust in our community. One, if our sheriff trusts us, that's a good thing. But also people need to see her in the community to see that she is trustworthy as well. And she cares about what is going on, and she always shows up, and she gets her blood pressure checked. So she shows the men that it doesn't hurt. Next slide. So from there, what we've learned is that since we can't get a bus at this moment, we will start creating health hubs. They cost me absolutely nothing to make because I have friends over in the carpenter shop, and they're just making these little hubs for me at no cost, as I know of right now, because I have not received a bill. And they are creating these, and they're delivering these health hubs. So these health hubs are truly a computer where someone can sit in the privacy of whatever location. One is at a soup kitchen, one is at the shelter. We have one at a barber shop, 2 at a church. We're getting ready to put 1 at a farm. And we're working on some other locations where the data tells us we need to go. But they can apply for a position. They can talk to a provider for free. Then it allows us to contact that contact that patient after they have that interaction, to talk to them about any other needs and connect them with a primary provider. Next slide, please. So through these, through this different work, we have learned that innovation happens in all different types of ways. We are still working to get our clinic. So we have a trailer that has 2 exam rooms, and twice a month, this trailer goes to our shelter. It's ran by our medical students. We are providing some of the resources, and it goes out twice a month. Our goal there is, again, to build trust, reduce recidivism. We're using our data to direct where we need to go. We have an AED program that we're working in close contact with compression shock. And we're focusing on getting these AEDs into our churches, to our community organizations. And that is our carrot, because the stick isn't working. So the carrot has to. And we get those AEDs. They're free because we have a grant that fund those. The churches are excited to get them because they know that it's needed. We're teaching them how to use the AEDs. The next day or the next week, we're sending them information about diabetes, hypertension, other resources. They can get one of these hubs in their churches. Then we're also talking to them about Blue Zone. And I'm not sure if everyone's familiar with it, but just a quick way, Blue Zone is just a different way of looking at healthcare. And we're talking to pastors who may cook a different way or may think a different way. And it has all of the components in it to improve the health and well-being of Eastern North Carolina. Having community conversations. We can do all of these things, but if we don't go back and look at our socioeconomic factors, we're not really doing anything except for giving people Band-Aids. So we're looking at how do we go back and look at generational barriers. So we started our Future Healthcare Professional Conference, and our goal is to look at those children who are in those red areas and expose them to healthcare. They don't have to be a nurse. They don't have to be a doctor. They can come and work in our organization. We are a little city that has so many opportunities, but if you don't know that you don't have to be a nurse or a doctor, you may never know that this is an opportunity for you to come. So this is our second year of doing this conference, and our goal is to focus on middle school and high school students. We're looking at data to direct us to go into our food insecure areas. So we are delivering Meals on Wheels, but we use that data there to look at our patients to understand who they are. So if we deliver a meal today and tomorrow they're not there, we're putting that into our health equity dashboard to say, Miss Jones wasn't there today. Let's look and see what's going on with her. But Miss Jones isn't there. She's probably hopefully she's going to come home. Let's connect them to our telehealth program and get her a monitor that goes into her house so we can monitor her for a certain point of time. Because if she went in for something small, let's try to prevent or eliminate the chances of her coming back in for that small thing again. Maybe it's something that we can provide resources for her. Summer feeding program, again, in succession, looking at our children, directing them, talking to them, putting our summer feeding program in communities that need it the most, and then sending home information for mom or dad or grandma or the neighbor to be able to have access. And our Food is Medicine grant. So this is something I'm super excited about. We have a grant through Blue Cross Blue Shield Foundation. And our goal there is, again, we have an open grocery store that's in the community on Wednesday. The doctors, the providers, the receptionists directs the patients to that clinic. They go there and shop. Again, the beats never leave, but they keep taking them back because they're good for your blood pressure. But they go there, they can get free food, and we're monitoring the impact of them going to that cart. We're asking a couple of questions at the cart, and then they're having that two-way conversation with the doctor. I went to the cart, I'm learning how to cook different things. We're giving them recipes. We have access to a dietitian there, and then we're working on getting the clinical staff on the Blue Zone program. So it's truly the staff is taking care of the community, and we're taking care of the community. It all goes back full circle. Next slide, please. So in the beginning, I showed you that boring little sandcastle, the one that in the beginning, we all know that it starts at our foundation. But if we all work together, we can create something amazing and beautiful. Maybe not like this in the beginning, but we can create something amazing. In this picture, you will see different ways that we're getting out into our community. We invited Black pastors to come in and talk to our CEO. They were amazed that he would even take the time to sit and talk with them and listen and explain things to them, because one, the church and a lot of community is the head of that community. So we needed to explain things to them so they could be able to go out and articulate it. We took employment in the bottom, those three ladies, we took them into the community. We did little vegetable boxes. All of my things died, but we gave food to the community for them to plant. We can give someone food, but if we teach them to fish, they will live for a long time. So we taught people how to plant, and they took home these vegetable boxes. Again, mine all died. We had mental health there so that mental health could talk to our community, because in some locations it's very taboo. So we wanted to have mental health there to have conversations. So my call to action to you all would be, one, throw noodles at the wall, have fun, get the walls messy. Every now and again, throw some pasta there as well. Throw tomato sauce there to mix things up a little bit. A no is a delayed yes. I tell my boss that all the time. You tell me no now, that just means come back to you again. And at certain times, particularly when he goes on vacation, I normally get a yes when he goes on vacation. Be okay to breathe and focus on the overall goal is to improve the health and wellness of your community. Thank you for an opportunity. Next slide. To discuss what we are doing in Eastern North Carolina.
Wonderful, Dr. Jackson. Thank you so much for such an inspiring presentation. All the presentations have been absolutely amazing. I encourage the lounge participants to please include your questions in the chat. We'd love to continue this robust conversation and really address some of your questions. And I'm just kind of rolling through. And if it's okay, I'll just kind of start reading. A question from Cheryl to all of you. Can you use nurse practitioners rather than physicians?
Absolutely. So that's one word, yes. In Texas, we still have delegation agreements that are required for our state. I believe North Carolina and Alabama the same. So we are working on that, but the answer is yes. And as a matter of fact, I stand firm that this will, in fact, be a nurse practitioner-led initiative. It will take nurse practitioners to get out there and go to these communities, because that right now we don't even remotely have enough physicians, as that one slide I spoke to said. But yes, absolutely.
All of our units use nurse practitioners on their units, and they do have collaborating physicians, because Mississippi and Alabama are collaborative states, is what it's called in both of these states. But yes, it's absolutely nurse practitioner driven and nurse led.
Mm-hmm. All of that, yes.
Wonderful. Question from Catherine. How do you navigate liability for a mobile clinic?
So we, Barb and Kashida may have some better information, but we are working with federally qualified healthcare centers, and those units are actually credentialed through those particular federally qualified healthcare centers, and one is an aid service organization. So all the liability is through them. And then, of course, we have liability insurance for our students through the university.
And ours is very similar, Emily. It's the mobile unit that we had, the Intune, was through the FQHC. They owned it and they insured it, and we insure our students as well. But yeah, but we did, when I was writing the grant, we did call our departments at the University of Texas at Tyler and ask them, what would be the insurance on this? What am I going to use as a number? Because this is a component that I need to address in writing this grant. So it's, you can talk with your university and they can give you an idea, because they will have something else usually comparable in their system that can give you an idea of what the insurance would cost. Mm. And it has to be written that way. You have to write it in scope. So writing having that mobile unit in scope can take a long time, but you have to get that done as well.
Just to add one more little comment to that, yes, our work is underneath our medical group. But before we do anything or focus anywhere, we make sure that we are talking, of course, to our legal team and our risk management team, because they keep us out of trouble and they want to make sure that we are not stepping into more than what we can handle. So we take small focus areas. So it's a 3-prong effect for us.
Wonderful. Question from L. Simmons. Is there an accrediting body for mobile units?
Well, not that I'm aware of an accrediting body. I mean, there's certainly scope. You have to have a scope that mobile unit falls into. And I know that there's mobile healthcare organizations, mobile healthcare associations. But to my knowledge, Emily, do you know of I don't know of an accreditation body. You just it has to be in scope.
Right. And it's more of the clinical concept of, the unit or the organization has to be credentialed, usually through the state. Right. So there's a term I'm missing, but there's is it called CWA when you have your lab accreditation?
Well, yes. That's so part of it.
So there's those types of things that have to be done separate from, the standalone buildings. But it's, again, usually through some sort of healthcare organization. So if you're going to do it through a university, you're going to have some sort of healthcare component through that. If you're going to do it for, as a nonprofit organization, you're going to have a clinical component to that and go through the state board of health or whatever the credentialing process is for getting a lab and or clinic credentialed through the state.
And that's exactly right. Because when we initially started, when Dr. Reiser wrote the Intune grant, we did not have a medical school affiliate. Now we do, which is why I talked to them last week. They just opened and I'm on their door because we need to do this now. That's why we got that done. But now we do. Yes.
CLIA. That's right.
Yeah.
Thank you, Jill.
Question from Jennifer. How do you begin to write the SOPs for the mobile unit?
Well, and that's the scope, so the scope of it would specifically, I think with ours, and I can just speak to ours, since we partnered with Special Health, the FQHC out in East Texas, our scope was based on what the services were provided by the FQHC. Now on the unit, the Intune mobile unit, I was able to do pretty much every single exam that you could do in a healthcare clinic. I did pap smears, I did STD testing, I did blood pressure analysis, I did lab draws, everything almost we did HIV, Hep C testing. We also had, food days, things like that, Kashida, which were wonderful. My favorite part. But we followed the same basic scope of practice that the FQHC had offered. And by having that FQHC overhead, that lets us, if I have somebody who comes in and they need cardiology, or if they're pregnant and they need follow-up care, that lets me immediately refer them into that FQHC system with a provider. They're already in the system. They registered through us and they can get to that provider.
We have a similar process. We have two QHCs and the AIDS Alabama South Shell Health that already have a scope of practice, and every single day has a kind of a different focus. Sometimes, again, a lot of times it's health screenings, but sometimes it can be full histories and physicals with, initiation of primary care with, follow-up appointments that are made at the clinic. So I think we're probably getting to this, but I think someone asked a question about follow-up, and it's typically not done at the unit, but it can be. Typically it's done, at whatever, either the federal healthcare center or one of the other free clinics or health departments in our region.
And we have some of the similar processes. So working with Access East, that's been one of our partners in the past, working with our FQHC. So those who we know, who we have the opportunity to meet, our goal is to try to connect them with the social worker, because it's doing just the pop-ups there, doing focus areas of care, that's not going to always address the larger needs that they have. So having that connection there has proven to be very fruitful.
Wonderful. And this question, could this work for the needs for the nurse practitioner preceptor?
Oh,
And Emily, I know you went ahead and answered that. Yes, we have RN, BSN, and APRN students, but would love Barb and Kashida to chime in on that.
yes, absolutely. We would have students on our mobile unit. Specifically, we would bring them in in our family nurse practitioner program specifically. Right now, we're looking at another grant that we're just starting to write, and it's going to be for mobile behavioral health, mobile mental health care. So, our PMHNP students. And so what we're thinking is the idea with that would be to put 1 or 2 PMHNPs on that while we mentor our own. I want to know that my students are being mentored by who they're being mentored by, and that they're being mentored by one of us, because it's such a variety out there when you start looking at who are the preceptors. So that's one of the key components that we're looking at.
And just to echo that really quick, so we are fortunate that we have a new dean, not a new nursing school, but a new dean who's joined ECU Health. And part of his goal is to have nurse practitioners to be a part of this work that we're doing. So it's two-pronged for us. So working with the nurse practitioners who are currently going through school, but then working with our nurses who we have hired to go out in the community to see these innovations. We want them to understand their community. When patients come in and they are, and I'm doing the bunny ears, non-compliant with different things, they need to understand, why is Ms. Jones non-compliant? Is it because Ms. Jones just doesn't want to take her medicine, or is she making a choice between food, transportation,
Right.
or medication for someone else?
Right.
So trying to move the way that I remember community health rotations were for me. We went to the health department and they came to us. Having the nurse practitioners there with us, seeing those patients, it helps hopefully change their mindset, but doing the same thing for our nurses as well, having them understand why our patients are coming in with blood pressures that are 200 over 180. So.
Barb, there's a question specifically for you. Do you know if any of the mobile clinics have targeted RV dwelling nomads, i.e. people living on public lands or campgrounds and vehicles? How do you manage specialty referrals?
Well, so I do not know that yet. But that is, that's a great population to address, because that is such a specific underserved group of folks. They are really isolated, especially in the older communities there. If you have an older population in some of the RV parks, they are very isolated. So, I think that's something to consider going forward. And I think to get that, so when I, for example, decide that we're going to try to go to a specific town or city, or an area, we have to meet with the city council. We have to get approval. We can't just, one day say, oh, we're going to go ahead and we're going to go to New Summerfield. No, we had to meet with the city council. We had to talk with them. We had to find a place to go. We had to make sure that it was safe. So, I think that that's a great idea. And I would love to explore that going forward, especially if we had a map specifically of those different locations, and going forward in the state of Texas, I have a plan where I have zones, about 24 zones around the state of Texas where mobiles will go, but you will just do a circle in this zone. And so in that specific zone, it would be about a 1 month time. The same nurse practitioners would go to that zone, but we'd be 3 days, 3 days, 3 days, 3 days. So we would be in 10 different locations for that. So if you see me on a Monday and I do your lab work, and specifically with the Piccolo, that is CLIA waived. So I don't need to get a CLIA certificate for that. And you have a problem, or if I want to see you in the next month, I can say, I'll be back here in a month. I'll see you again. In the meantime, if you have a problem, you can get us on telehealth. So I think looking at those or redefining those zones might be a great way to add to that. And include some folks, because even in the zones that I'm trying to develop for Texas, that helps us reach 7.2 million Texans. It's a big job.
Emily, a question for you in the chat by Ruth. Any tips on demonstrating demonstrating need in a population for whom national statistics are lacking, i.e. nomads, no demographic variable for geographic mobility in national surveys. Any thoughts on
Yes,
that?
and similarly, I don't have a great answer for that. I think what you would have to do is kind of back into that and figure out what do a little of your own research, et cetera, about what types of needs exist in those types of communities, and then back into it, or what types of individuals are in those communities, and then back into it to say, okay, and I'm making up numbers here, these are not real numbers, if 50% of, the individuals are elderly individuals that, lack some sort of Social Security benefit, well, then you can probably use that statistic with another statistic to prove, what it is that you're looking at. But again, that's probably you're going to have a lot more groundwork on that type of experience.
Thank you. And then a follow-up question. Have you encountered state line boundaries to providing care with mobile clinics?
Our mobile units pretty much are within the geographic areas that they serve. So they already have a defined area that they serve with the federally qualified healthcare center or the different services. So they travel within their service region.
And that's similar. Yeah, that's similar, Emily, to what we did. Now over in Far East Texas, one of our healthcare centers was up far northeast at Texarkana. So it was on the Texas-Arkansas border. We did not cross over into Arkansas, but we probably could have had we had more manpower to do it. During COVID, with the COVID money and the COVID grants and the fact that we did so much COVID testing, the FQHC was actually able to purchase 2 more, because you got to look into this. They were able to purchase 2 more mobile units, not just our little first one, which is my favorite, but they have 2 big ones now that they're taking out. So, that's a different scope issue. The smaller ones that it looked like Emily was using are a little bit easier to maneuver. Not as big of a financial issue as well either. But I think we could cross state lines as long as it was in the scope of the facility that we partnered with.
Fran has a question about financial support beyond HRSA. Do insurance companies support these services?
If it's through the organization, then yes. A lot of times the organization has multiple different funding streams that fund this particular type of work. And then, they can bill insurance for these things. So there's some, documents that these individuals fill out, et cetera. Other types of experiences that have different funding streams or funding lines are completely free services. So it really depends on how you set up those services.
So specifically the specialty vans that you spoke of earlier, the mammograms, the people that come in with radiology. I mean, those are specific to organizations often. We have the mammogram centers down here in Texas. So if it's affiliated with that, a lot of times, up in Virginia, they had their own mammogram. It was owned by just one of the physicians there, and he was a radiologist. He just bought it, and he does free chest X-rays because they're in coal country, and they have the largest black lung ratio of any other place in the world.
Wow.
That's Dr. Smitty. Dr. Smitty.
Another question for all of you. Have any of you used the mobile units for staff training or simulation across various settings for your healthcare systems?
I've not used it.
Oh, go ahead.
I was just saying, I've not used it in that capacity, no.
Not yet, but there's University of Texas at Arlington over here has a big training facility in some of their mobile units. And they actually take students on and they go into different areas with students with sim labs. They have the sim lab built on the mobile. I'm so jealous. So, and it's wonderful. And they can hit these areas up at Wichita Falls where, and they go to a whole different area. But yes, you can put sim on this.
So the short answer for us is not yet. But we are working with the College of Nursing to see if there's an opportunity to do that. The closest we have gotten to doing something similar is having our nurse residents sign up for 4-hour blocks to come out in the community and work some of these stations, particularly the ones that are hypertension, our diabetes, and our BMI screening station. But we have not done that yet. So I will throw that against the wall. That is something that we need to consider.
Question from Nikki. Are your grants able to help folks get access to internet or technology?
So for us, that is a yes and. We are working with our grants department and our innovation director to see about any type of broadband access that is capable right now. So we are looking at technology that does not require to have broadband. They're already Wi-Fi equipped, and it would be paid for through a grant that we already have some of this equipment. But unfortunately, even where I live, we struggle with really good access. And we're in a well-populated area, but our internet in certain locations, different times of the day is spotty. So that's hopefully with Metronet coming here. I don't know if you all know anything about that. We will have some better service, and they're promising that they will do more community innovations to push things out to these different areas.
We had, and we struggled with that quite a bit initially when we went out. And I'm just looking at East Texas, that East Texas region. Now, Texas is a big state. East Texas is what they call the piney woods. And so you have to pull the pine curtain, right? So everybody's behind the pine curtain, so they call it. And so initially we chose our locations based on where could we plug in. So for our first example, we were next to a fire state or to the police station. So we would run a long cord and plug in, and they would allow us access to that. Then we went to MiFi. So we were able to use, it's called MiFi with splitters, so that we were able to get more access to the different computers that we had on board. But in terms of our populations, like I mentioned before, Texas is a huge digital divide, and the legislators are working on how do we address that. Well, there's a lot of problems in Texas, and that's a big one. So,
and the only comment I have on that so far is we have started the process of purchasing mobile hotspots for all of the units to do direct telementoring, but not necessarily directly with the patients, more with the students and with the preceptors, preparing for our Project Echo and that kind of thing.
Yeah. I've even had on the free mental health care outreach line, I've had teachers come on, and they would have to actually stay in whatever, if they were elementary teachers or high school teachers, they would have to stay on their campus. I had one, God bless her, for several sessions. She would get in a closet at her elementary school and would talk to me from the closet in the elementary school, because that's the only place she had access.
I just want to thank Dr. Bentley, Dr. Chapman, Dr. Jackson for such an inspiring and meaningful innovation lounge. I hope that you've been able to see some of the love in the chat with all of this has been so inspirational and just really moved and called to action by your work. So just to thank you so much.